Good day, and welcome to the CAP webinar, The Final 2025 Medicare Policy and Payment Changes for Pathologists. I am Pamela Yazdani, the Senior Director of Economics and Regulatory Affairs at the College of American Pathologists. During the next hour, we will discuss the final regulations and policies for the Medicare Physician Fee Schedule and Quality Payment Program that will be used to reimburse pathologists in 2025. Before we get started, I'd like to review a couple of technical details about today's presentation and introduce you to our presenters. We want to encourage you to type your questions in the chat during the presentation. There will be a time at the end for our panelists to address them. We will select questions that are a representative sample of those submitted during our limited time here today. An archived recording of the webinar will be available later next week. The CAP will have a link to this presentation, along with a PDF of the slide deck in the webinar section of the cap.org website. Now, let me take a moment to review our agenda and introduce our presenters. Next slide, please. Our first presenter is Dr. A. Joe Saad, Chair of the CAP's Council on Government and Professional Affairs. Dr. Saad is also a member of the CAP Board of Governors, Chief of Pathology for the Methodist Health System in Dallas, and Adjunct Associate Professor of Pathology at the University of Texas Southwestern Medical Center. Next slide. Our second presenter is Dr. Ronald McLawhon, who is the chair of the CAP's Economic Affairs Committee and a member of the Council on Government and Professional Affairs. Dr. McLawhon is also professor and vice chair of pathology and director of clinical laboratory at the University of California, San Diego. Next slide, please. And our final presenter is Dr. Gregary Bocsi. Dr. Bocsi is the chair of the CAP's Quality and Clinical Data Registry Committee and a member of the Council on Government and Professional Affairs. Dr. Bocsi is an associate professor of pathology at the University of Colorado School of Medicine. And now it is my pleasure to turn the presentation over to Dr. Saad. Next slide, please.
Thank you, Ms. Yazdani, and good day to everyone. Thank you for joining us for this webinar. If we could go back one slide, I think. The agenda slide. Okay, let me go ahead. Okay, there we go. All right, so this is an overview of today's agenda. First, I'm going to start by discussing our payment policy and advocacy agenda. After that, Dr. McLawhon is going to go over the final 2025 fee schedule changes and look at some of the impact on our pathology codes for 2025. And after that, Dr. Bocsi is going to give a very thorough review of the final 2025 quality payment program policy, looking at present and future changes in the program. And finally, at the end, we should have plenty of time for questions after that. Next slide, please. So the proposed Medicare physician fee schedule was released in July, and that opened up a 60-day comment period. After that, CMS looked at all the comments and then released the final regulation on November 1, 2024. These final regulations will go into effect on January 1 of 2025. Now, on November 1, right when the final fee schedule was released, CAP members received a special advocacy update with an initial analysis of this regulation. Today, we're going to go into more details about the CAP findings with this regulation. I want you to know that CAP will continue to engage with CMS and continue to engage with Congress throughout the rest of this month into next year and beyond on the fee schedule and on the updates that we hope to implement going forward. Next slide, please. So CAP and the AMA and other physician specialties are pushing back hard for Congress to fix Medicare's cuts once and for all. Over the last 6 years, payments to pathologists have decreased by approximately 7%, while physician practice costs have increased by over 17%. This downward trend continues in the final rule. These cuts are on top of a lack of an inflationary update to the physician fee schedule. According to the AMA, Medicare physician pay fell 26% between 2001 and 2023 because physicians do not get this yearly update. As a matter of fact, through 2024, the number is down 29%. Others that are paid through Medicare do get updates. For example, those that receive payments through Part A, such as hospitals, surgery centers, skilled nursing home, and LTACs, get an annual update, but physicians do not. This is unsustainable. We get cuts, we don't get updates, but we need to be updated to keep pace with inflation. Next slide, please. So here you can see graphically the growing gap between Medicare pay and inflation. In 2025, medicine overall is slated to get about a 2.8% cut because of an adjustment to the conversion factor, which Dr. McLawhon is going to discuss in detail shortly. That translates into a cut of approximately a negative 2.5% for pathologists. Physicians' practice costs have gone up markedly, 17% since 2020, and you can see graphically the delta approaching a negative 24.5% when we adjust for a decrease in payments and the cost of inflation. Congress must act to stabilize Medicare payments with an annual physician fee schedule inflationary adjustment. I just want to mention the Medicare Economic Index, which is the red bar that you see there going up. This is a measure of practice cost inflation that was developed in 1975, and it mostly is composed of two factors, the physician practice costs and the physician compensation. The Medicare Economic Index for inflation is estimated to be approximately 4.6% in 2024. You're going to hear a lot about this, so I just wanted to clarify what the MEI is. While we continue to tell Congress that short-term fixes to Medicare's payment system are still required, Congress must act once and for all to provide a Medicare inflationary update to improve the financial stability in the physician's fee schedule. This was one of our featured asks during the Hill Day of April 16th of earlier this year, and our ask continued throughout the summer into the fall and will continue until the end of the month and beyond into 2025. Next slide, please. So our asks of Congress are to fix Medicare payment. This began, as I mentioned, at the Pathologist Leadership Summit, which in April focused on improving Medicare payment for services you provide to patients. We asked Congress to support the Strengthening Medicare for Physicians and Providers Act, or HR 2474. This legislation would apply an inflationary update to Medicare's physician fee schedule. This would be the first step in the process of providing crucial financial stability until additional permanent bipartisan reforms are enacted. Our second ask of Congress was to support the Provider Stability Reimbursement Act, or HR 6371. This increases the budget neutrality threshold from 20 million to 53 million and increases that threshold every 5 years by the cumulative index in the Medicare Economic Index. It also provides for a look-back period to reconcile overestimates and underestimates of pricing adjustments for individual services. For example, right now, if Medicare overestimates the amount of payments they're going to make by $1 billion and they don't spend that $1 billion, that's gone. We want it to go back into the physician fee schedule. And it also requires timely updates to the direct costs used to calculate the practice expense RVUs. And finally, it requires the secretary to limit positive and negative increases in the conversion factor to no greater than 2.5% up or down. Next slide, please. Finally, Medicare's clinical laboratory fee schedule needs a permanent fix. This has been in flux as a result of PAMA passed in 2014. And as a result, we saw cuts of approximately $3.8 billion out of a total fee schedule of around $8 billion, so almost 50%. For the past few years, Congress has stopped the cuts of up to 15% annually in the clinical laboratory fee schedule. However, we're asking members of Congress to co-sponsor and pass the bipartisan bicameral Saving Access to Laboratory Physicians Act, or SALSA, S4449, which provide a permanent fix to this flawed methodology. Recently, we've heard that ACLA is considering an alternative approach, and we're waiting for the legislative language before we decide on how we're going to react to this. But essentially, it would freeze the rates at the 2019 level and apply inflationary updates based on the consumer price index annually after that. There's pluses and minuses to this approach. One of the minuses is that it freezes it at a fairly low level, 2019, and it doesn't provide any updates since this was established. These rates were established in 2017 or so. One of the pluses is it's at least providing an inflationary update, but we are waiting for the legislative language before we take a position on this. Currently, we support SALSA. Next slide, please. And with that, I'd like to turn the presentation over to Dr. McLawhon.
Thank you, Dr. Saad. Could I have the next slide, please? So I just want to go over the overall payment changes for 2025. As Dr. Saad mentioned, the conversion factor for the 2025 fee schedule payment formula was decreased by 2.83% relative to that of the 2024 fee schedule. That's for physicians overall. So the decrease in the conversion factor is primarily due to two factors. First is the expiration of the 1.25% relief that we saw from the 2023 Consolidation Appropriations Act, and then the supplemental relief that was passed in March of 24, which represented 1.68%. As a result of the changes, the CAP estimates for pathology at minus 2.54 overall percent impact to Medicare payments. Obviously, it's a little bit lower than what cuts for physicians in general. And we'll get back to why that's occurring. And it's 2.65% when you consider the payments to independent laboratory from Medicare. To review the detail of the changes, please look at our final 2025 Medicare physician fee schedule impact table available on the FCAP.org website. Have next slide, please. So in I just mentioned about the fact that our cuts are a little bit less than what the overall average for the physician in other specialties average was. And that's because the success of our advocacy over the last few years in getting clinical labor pricing updates. This is our fourth and final year of non-physician clinical labor staff cost inflationary updates. These are primarily those related to the histotechnologists and cytotechnologists. As you recall, CMS agreed to this, all of CAP's recommendations. And again, this was very significant efforts in two separate years to increase first the rates for the histotechnologists and then the cytotechnologists. So, the impact on revised labor rates were based on the applied practice, CMS practice methodology. This increased both the TC payments as well as the global payments for many pathologist services on the fee schedule. Overall, this represents approximately $12 million each year to pathology and independent laboratories. This effectively offset the reductions from budget neutrality adjustments that came with the conversion factor. Now, within that, budget neutrality realm, while the update will positively impact some of our services with clinical labor, it would also negatively impact those that are relatively more supply and equipment intensive. So there's trade-offs working within that budget neutrality construct. Next slide, please. As you may know, there are new CPT codes for 2025 for chimeric antigen T-cell therapy. We were successful with other medical specialties in advocating for creation of 4 new category 1 CPT codes for CAR T cell services, and a new subsection of the CPT manual with reporting guidelines. These were originally category 3 temporary emerging services and procedures that were used for tracking purposes since 2018. And we have now moved them to category 1 status. Next slide. These were then subsequently taken to the RUC, and the RUC did accept the valuation of these 4 codes. However, CMS did not accept in the final rule payment of the 38225, 226, and 227 codes. These are the ones that are involved with the harvesting and preparation for transport and preparation for administration. They did approve the 38228, which is the administration code. So the reason, though, the first 3 codes were not accepted by CMS is Medicare has a policy of not paying separately for each step used in the manufacturing of a drug or biologic. And this really goes back to when the category 3 codes were first created. This has been their policy all along, not to pay separately on the PFS or the outpatient prospective payment system for these services. These are all bundled into basically the product manufacturer, and those are recognized by CMS through the level 2 HCPCS systems, either with, depending on what the product is, as a Q code or a C code. CMS does display the RUC recommended work reviews for these services as they do for other bundled services on the PFS. However, they will remain non-payable. They can be used for tracking purposes and reported for tracking purposes. So the only one that CMS will pay for separately is the 38228 administration code. Next slide, please. We also were successful with therapeutic apheresis advocacy. This is in a non-facility setting, so this really affects the CPT codes 36, 514, 516, 522. This would be plasmapheresis, as well as the immunoabsorption column pheresis and photopheresis codes. At the RUC meeting, CAP led a multi-specialty group to revise the clinical labor staff type from an RN LPN blend to an oncology nurse, which was recommended by CMS and the RUC as a apheresis nurse proxy. So those recommendations were forwarded to CMS and accepted. And CAP advocacy increased reimbursement for the apheresis services to negate cuts in the non-facility setting. Next slide, please. Just to look at some of the changes to individual services, if we look at our, top 6 codes, whether it's the 88305 or 307 tissue codes, or the special stains codes, the 88312, 313, or the immunohistochemistry codes, 88341, 342, you can see for the professional component, the -26 modifier services, the averages are between 2 and 3% in terms of the reductions. If we look at the technical component on the bottom of the slide, again, 3 to 4% reduction, with the notable exception of the immunohistochemistry codes, which went up by about 5 to 6%. And then when you look at the blended rates for global, you can see that those are hovering in the 3 to 4% range. Next slide, please. So what were the largest changes in pathology payments? So we have winners and we have losers. And this is all related to CMS's methodology. So obviously we saw a very significant increase related to the apheresis code 36516, 17% change. That's reflecting that clinical labor change, changing to the oncology nurse as a proxy for an apheresis nurse, but also some supply changes. You can see analysis skeletal muscle, both the technical component and global fees have gone up significantly. The 88342 first antibody, as well as each additional antibody went up significantly. Where things went down, immunofluorescence codes, mainly the technical component. The DNA ploidy analysis went down by about 8%, and then the 88374 went down by about 8 to 9%. So, and 88374 decreases not due to any change in physician work or practice expense inputs, but it's something in the nature of the way CMS is calculating this in practice expense methodology, and we're reviewing these decreases carefully, and we'll follow up with CMS on both the global 88374 and the 88374 technical component. So with that, I will now turn this over to Dr. Bocsi, who will review the finalized changes to the quality payment program and MIPS requirements for 2024.
Okay, thank you, Dr. McLawhon. So if we can go to the next slide. As many of you recall, there are two pathways under the quality payment program, MIPS and APMs. And MIPS is the pathway for clinicians under the QPP who don't qualify as a participant in an advanced alternative payment model. And as you probably heard before, CMS has indicated that they want all beneficiaries in an accountable care relationship. And that means all physicians in value-based payment arrangements by 2030. And in fact, CMS would like to see traditional MIPS go away in favor of advanced alternative payment models. That's not currently realistic, though. So in the interim, CMS has a transitional pathway, which we've discussed before, between MIPS and APMs, and that's called the MIPS Value Pathways, or MVPs. If we can go to the next slide. So if you've been counting, we're in year 8 of MIPS now, and CMS tends to increase the requirements for successful participation as years go on. Two ways of doing that include increasing the minimum number of points needed to achieve a neutral payment adjustment, as well as the percentage of your cases that must be reported to CMS. So for 2025, CMS is maintaining the performance threshold and data completeness levels at 2024 levels. And in fact, CMS is keeping the 75% data completeness threshold through calendar year 2028, which is higher than we would like, but still better than a previously floated 82-point threshold, which would have resulted in many more MIPS eligible clinicians receiving a negative payment adjustment. CMS backed off that proposal, and hopefully that signals that they recognize that rapid increases in the performance threshold and data completeness are impossible for clinicians to sustain. So mostly steady on these two fronts for 2025. Next slide. So then for scoring, as I'm sure many of you have heard before, as non-patient facing clinicians, pathologists are scored on quality and improvement activities predominantly. Quality measures can continue to be proportionally the most important, particularly for large groups, which CMS defines as groups with more than 15 pathologists. And for these large groups, quality measures constitute 85% of their total score. Scores for small practices are reweighed, so the quality and improvement activities are each 50% of the total score. Non-patient facing groups and individuals automatically qualify for reweighing of the promoting interoperability and category. And pathologists are almost never attributed to cost measures because all of the cost measures that exist currently are assigned based on specific trigger codes, none of which are codes that pathologists routinely bill. So what you see here is that below 75 points will lead to a negative payment adjustment. 75 points exactly will result in no payment adjustment, and scoring above 75 points will qualify for a positive adjustment. As I sort of indicated earlier, 75 points is a high bar, particularly for larger practices, and CAP is vigilant and advocating for a reduction in burden for pathologists so that we can be successful in the MIPS program. Next slide, please. All right, so the next three slides, the first one is kind of like neutral, then positive, then kind of negative. So neutral, one aspect of MIPS that isn't changing is the pathology quality measure set. So there remain 7 quality measures available for reporting by any MIPS eligible pathology practice. No additions or subtractions for 2025. Next slide. Now this is good news. So for 2025, CMS is changing the scoring of our topped out QPP measures so they can be worth up to 10 points again. So if you see there on the left, many of you may remember, topped out measures were capped at 7 points. And actually, if you look closely at the table, it was capped at 7 points, but in fact, if you got anything less than 100% performance, you were getting, substantially less than 7 points even. And so why this is really favorable for us is if you look on the right now, the topped out measures not only qualify for up to 10 points, but there's actually a full spread of scoring available based on your performance. Now, at the low end, there won't be points, but because they're considered topped out because of overall excellent performance by pathologists, we see this as a win for us. Now, it's not guaranteed. They can change this next year, but for 2025, this is how it'll work. And so the next slide, I guess, is kind of the bad news. Changes to improvement activities. So CMS is eliminating 4 improvement activities that are commonly reported by pathologists. So we, strongly advocated against this, but they basically declared that they consider these activities obsolete, despite our disagreement. And so, the way we consider this unfavorable because IAs are 15% of a pathologist score for a large practice or 50% of a pathologist score for a small practice. So having a nice inventory of improvement activities to report is a priority for our committee and for the College of American Pathologists. You'll see that 2 of them are kind of like delayed removal, but ultimately this year, and then subsequently, there will be a reduction in improvement activities available and not just any improvement activities, but improvement activities that pathologists have used in the past. So if we can go to the next slide. I talked a bit about, I mentioned the MVPs, right? So the MIPS value pathways. And CMS continues to roll these out, and the next slide will show you some of the other specialties that they've tackled already. But the idea is that this is sort of a transitional tool between traditional MIPS and advanced APMs. So they're intended, in theory, to be a coherent set of activities. So quality measures and cost measures, as well as improvement activities that combine to focus on a particular area of practice and to sort of balance out the give a well-rounded perspective on how well one is doing in terms of all of those things, quality, cost, and practice improvement related to a specific clinical topic. Particular elements of MVPs that you can imagine are potentially difficult for pathologists to participate in are the promoting interoperability and the population health measures, which currently don't apply to pathologists. So we are engaging actively with CMS to help work this out for pathology. And I wouldn't be surprised if a pathology MVP is proposed by CMS even as soon as next year. So if you go to the next slide, and this is why, is that they're walking across the landscape of medical specialties, crafting MVPs to try and cover sort of all types of clinicians. So the new MVPs for 2025 are in the green box here. And CMS has not explicitly included pathologists in the MVPs yet, but they have included 2 pathology measures in the dermatological care MVP. So we keep a very close eye on this. And as I mentioned, we're engaging with CMS to help understand how pathologists will be able to successfully participate in an MVP in the future. Next slide, please. And, as I indicated earlier, the long-term vision of CMS is patients, providers, and alternative payment models. They're continuing to push that and working on efforts to shift clinicians into advanced alternative payment models and accountable care arrangements. And their goal is 100% of traditional Medicare beneficiaries in these types of relationships by 2030. Eligible clinicians who meet threshold levels of participation in an advanced APM become something called a qualifying participant, and they are exempt from MIPS. And CMS assesses the level of participation based on payment amounts or patient counts using threshold percentages and calculate a ratio of attributed beneficiaries to attribution eligible beneficiaries. So the final rule this year includes changes to some criteria used to define attribution eligible beneficiaries for the purposes of QP determination. And then the final rule also reflects some changes made by Congress that includes continuing an APM incentive payment amount for performance year 2024 of 1.88. And again, just reflecting again, a continued emphasis on this being sort of the direction that they want to go in the future. If we can go to the next slide, please. So just broadly speaking, pathologists aren't alone in dealing with the quality payment program. And so the College of American Pathologists coordinates with the AMA and really all manner of other specialty societies when it comes to protecting independent practice and the right to practice medicine in a variety of contexts. And that includes specifically advocating for maintaining traditional MIPS and specifically reducing the burdens associated with participating in MIPS. So, our committee, the College of American Pathologists, we investigate ways that pathologists can meaningfully participate in independent practice and engage with ACOs and APMs. But we don't want pathologists to be forced to consolidate or merge with other practices in order to be able to do that in the future. If we can go to the next slide, please. And so another member benefit that I hope many of you are aware of is the Pathologist Quality Registry. And this was really created to help our members be successful in the MIPS program. The registry has excellent staff that will work with your practice to help you navigate the MIPS program and maximize your bonus potential. That includes looking at the measures that you'd be able to score most highly on, how to actually report, do your MIPS reporting, selecting improvement activities. They have expertise in all elements of the MIPS program and how to be successful using the Pathologist Quality Registry as a tool to again obtain the best bonus. And if by the way you have been relying on your billing company, you can certainly ask them to reach out to CAP on your behalf and sort of evaluate whether or not your MIPS strategy is really best suited for your particular situation and ability, and really maximizes your chances of getting a high score and a positive payment adjustment. Now, if you're not sure how you're participating in MIPS, there's the link right there on the slide, and you can input your NPI to check your eligibility, and there's the email address. If you have questions, don't hesitate to contact the CAP staff, who again are very knowledgeable about MIPS and scoring and how best to participate. That's it for me. I'm going to turn the presentation back to Dr. Saad for questions.
Thank you, Dr. Bocsi and Dr. McLawhon, for that overview. Very thorough. Thank you indeed. I'm now going to ask Ms. Yazdani if we have any questions. We should have plenty of time here, so please be sure and ask a question. And Pam, do we have any questions yet?
Yes, thank you, Dr. Saad. We can take the questions now, but I just want to remind our participants to please type any additional questions you may have in the chat or Q&A feature. Okay, our first question will be for Dr. McLawhon regarding the CAR-T codes. And the question is, I'm a bit confused regarding CMS decision on the new Category 1 CAR-T codes. Can you please clarify?
Thanks for the question. So let me clarify that the CMS's policy was not what the CAP or the other medical societies advocated for. So we will continue to engage with CMS on this. We're going to meet with them over that. Basically, again, they created the Category 1 codes from the Category 3 codes and followed that basic structure. However, CMS had a longstanding policy by basically saying that anything that's involved with the manufacture of a product, biologic or drug, is not paid on the physician fee schedule or under the outpatient prospective payment system. So they've made a decision for the harvesting steps, for the preparation for transport and preparation for administration, to not pay for those services. Now, you can report those services, as I said, for tracking purposes to CMS. You can also use these codes for other payers. Now, whether the payers will pay for those services, a lot of times private payers will follow Medicare's policies. But this has been a long-standing policy with CMS. It may work for different payer groups, but right now, those first 3 codes that I showed are not being paid under the physician's fee schedule because of their policy. As I said, we're going to go back to CMS and discuss this with them and try to clarify their rationale as to why they continue with this policy.
Pam, I think you're on mute.
Thank you. Thank you, Dr. McLawhon. The next question is for Dr. Bocsi. We only get 7 points for the QPP measure, even though we've been scoring 100% on them for years. It looks like CMS is changing that. Will this make it easier to get more points for these measures? Is this change permanent?
Yes, so that's what I said, that this is good news, right? So CMS finalized a policy under which the pathology QPP measures are now we're up to, potentially, depending upon your performance, up to 10 points again. But that's if you score perfectly. But again, if you refer back to the slides, you see the table, you see your performance rate and how that would translate to score. So, very good news. But there's always a but, is that CMS is going to reevaluate the measures and the policy on a yearly basis. So we don't have any specific reason to anticipate anything changing between 2025 and 2026. But the change is this change in policy is not permanent. And so we can't guarantee how long this scoring strategy will persist for top ballot measures.
Thank you, Dr. Bocsi. The next question is for Dr. Saad. It's discouraging to see another cut in the Medicare conversion factor for next year. Do you anticipate that we'll see additional cuts in years to come?
Thank you. That's actually a great question, because I love to predict what Congress and what the administration, what CMS is going to do. So, we do have obviously a new president taking office in January. We'll have a new administration, and he's nominated new people to fill key positions, including RFK for Secretary of HHS and Dr. Oz for CMS. These are subject, of course, to Senate confirmation. So it's really difficult to predict what direction that they're going to take. However, it is a little bit encouraging. First of all, I want to say that even though we're facing a 2.8% cut across medicine, our efforts aren't done yet. We will continue to push for mitigation of that 2.8% cut. At some point, Congress is going to have to pass a spending bill, and we're going to be there asking for them to mitigate some of these cuts. And long term, we're obviously asking for the inflationary update going forward. But we're not done. We haven't thrown in the towel yet. Last year, it took us until March to get additional mitigation. And so we'll continue working through the end of the year, perhaps into the first part of next year. The thing to remember is that the main driver to the cut in the conversion factor is the implementation of the E&M codes. And as a result of budget neutrality, the specialists had to take a cut basically in order to give the increase for the E&M codes. Now, Congress stepped in twice to mitigate those with a Consolidated Appropriation Act of 2023, a 1.68% increase, and earlier this year with a 1.25% increase. So those are going to be expiring January 1 of 2025. Going forward, it's hard to predict if there'll be further cuts. We don't anticipate any drastic cuts, but it does depend on a few factors. For one, it'll depend on the physician practice information survey data that the AMA collected earlier this year, and that we'll be presenting to CMS. And the second thing is that CMS will be continuing to monitor the utilization of the E&M codes. If that utilization goes up significantly, we may see further cuts. If it stabilizes, we may not see any cuts. Really difficult to predict, but we will continue to push for mitigation of those cuts no matter what.
Thank you, Dr. Saad. The next question is for Dr. McLawhon. You highlighted in the CAP's advocacy leading to increased reimbursement for therapeutic apheresis services, but it appears that CPT code 36516 had a significantly larger increase relative to 36514 and 36522. Why did one code increase so much more relative to the other apheresis codes?
Good observation. Obviously, there was the increase that was related to valuing the clinical labor for the oncology nurse or as a surrogate for the apheresis nurse. But in the case of the 36516, there are other components there which on the supply side. And invoices were provided by us and the other specialty societies to CMS that basically accounted for the increase, the additional increases above and beyond the other apheresis codes. So that includes the immunoabsorption column. This is for the lipoprotein lipid apheresis, as well as some other components that are in the apheresis machines themselves, particularly connection pieces. So that's what's accounting for that additional increase.
Thank you, Dr. McLawhon. The next question is for Dr. Bocsi. I don't understand the new dermatology MVP. There are some pathology measures there, and we see a lot of dermatology cases. Should we report the MVP in 2025? Will that make MIPS easier?
Yeah, okay, so yeah, it's a bit confusing because CMS did include pathology quality measures in the dermatological care MVP, but that doesn't mean that it's intended for pathologists. And in fact, in the final rule, they stated something to the effect that this MVP is most applicable to dermatologists. It is not directed towards, pathology alone. So if you're a pathologist in a pathology only practice, even if you do see a lot of dermatology cases, you wouldn't report this MVP because there are not enough pathology quality measures for you to be able to score well. Now, I suppose if your practice includes, some dermatologists, you could consider reporting it, but because it's new, I guess our suggestion would be if you wanted to try reporting it, to report both the MVP as well as reporting as you would through traditional MIPS, if you want to give that a try. Because right now, MVPs are still optional. So I guess we would say be cautious if you're in a multi-specialty practice and you choose to report an MVP, because it's not sort of well established how that may affect things. As I mentioned, probably an MVP for pathology isn't too far into the future. And the second part of your question is, will it make MIPS easier? Well, we're hopeful and optimistic. That's why we're working directly with CMS when they ask us questions about MVPs or whenever they make any proposals about MVPs to sort of share our perspective on things. But would I guarantee that it makes MIPS easier? No, I also wouldn't guarantee that it would make MIPS fun. So we'll see what happens.
Thank you very much. And now the next question I have is for Dr. McLawhon. I noticed that for 2025, the technical or TC modifier codes seem to have the biggest decreases. Why are TC codes prone to such decreases?
So thank you for that question. And it's one thing and one thing only, having to maintain budget neutrality under CMS requirements. CMS is required to ensure the aggregate pool of direct expenses, practice expense for 25 does not exceed the direct practice expense cost from 2024. In order to do this, CMS has to apply an across-the-board scaling adjustment to direct practice expense in the practice expense RVU calculation. So as the clinical labor goes up, say from the histotechnologists or the cytotechnologist, there has to be compensatory scaling down adjustment to deflate the costs on the direct cost inputs for all services. So if the code is really very supplier equipment intense, that will get weighted heavily. Basically, the scaling adjustment is a combination of the conversion factor cut plus the scaling factor. So you basically wind up having to take something to pay for the clinical labor updates and the way to do that is you take away from the supply expense or equipment expense. So those that are very supply or equipment heavy are the ones that get affected more than others. This doesn't apply to our -26, the professional component procedures. It's just to the TC components, and you'll see some impact, but by extension into the global payments as well because of that.
Thank you, Dr. McLawhon. And the next question from the online chat is for Dr. Bocsi. And it is, while two key improvement activities, IACC1 and IACC2, will be deleted in 2026, is the CAP preparing alternative improvement activity options that are more applicable to pathology to be considered as replacements?
Yeah, so that's a very insightful question. I appreciate that. I mean, our committee, in fact, last year did just that, submitted recommendations for improvement activities to CMS, and we hoped that they would accept them into the program. They didn't, and so we actually had recently a follow-up meeting with them to discuss their thinking about not accepting them, and just to understand a little bit more, I guess, what they're looking for. They have like published criteria for expectations of improvement activities, but sometimes it's like the CLIA regs. There's room for interpretation based on what they're actually between what they have in mind and what they write on paper. So we met with them. We talked with them about what they're looking for, and so in fact, our thinking is that we should be able to submit additional proposals in the next year or so to CMS, and we're hoping that having worked with them directly on this particular topic, and specifically the team that evaluates them, that we'll be able to get some improvement activities that are very appealing to pathologists included in the MIPS program, and with a mind towards when a pathology MVP comes into existence, it will need improvement activities, and we'll have some very highly useful ones for pathologists that could then be included in an MVP as well.
Thank you, Dr. Bocsi. As we have no further questions, I will now turn the program back over to Dr. Saad.
Thank you, Ms. Yazdani. Can I have the next slide, please, so we can close out today's session? Please be sure and stay engaged with CAP, stay informed, follow CAP on social media. Our X/Twitter handle is @CAPDC Advocacy. Please follow CAP on Facebook and visit the advocacy page on the CAP website. This has recently been updated and improved, and we continue to update it all the time. So check back periodically to see if there's anything new. Advocacy Update, our newsletter, comes out every Tuesday afternoon. Look for it in your inbox. There's a lot of good information there. If you're not a member of PathNet, please join our grassroots advocacy network. And please plan to attend the HOD meeting and the Pathologist Leadership Summit, which will be held in Washington, D.C., April 26th to 29th of 2025. A lot of good things that are going to be going on. And of course, we end with Hill Day, which is very thrilling and exciting to go directly to Congress, meet with congressmen, women, and meet with their staff to advocate for pathology and for our patients. And finally, thank you for attending today's webinar. I hope everyone had a great Thanksgiving, and I wish you all a very, very happy holiday season. Many thanks to the CAP advocacy staff and the DC office, to Pam, Kristen, and all the staff there that work so hard on our behalf. And I hope you have a great rest of the afternoon. Thank you very much.